This is a case of left-sided undescended testis with congenital left-sided inguinal hernia. See the hemiscrotal deficiency. We are planning for laparoscopic assisted orchidopexy. For this purpose, through the umbilical port, which is 6 mm, we are going in with the help of 5 mm 30-degree telescope. You can see the appendix, the large sigmoid colon, the distended bladder, urinary bladder, and left-sided iliac vessels, as well as the medially the you can see the deep ring area, the left-sided uh, medial umbilical ligament and inferior epigastric vessels, as well as the triangle of Doom, that is testicular vessels, the vas deferences, and in between this remaining the iliac vessels, the distended urinary bladder. You can see the tortuous veins. It is we are going to the right side. The appendix along with cecum, the right sided vas, testicular vessels, and external iliac vessels. Now we are concentrating over the left side, and we are trying to searching the testis, and we have to follow the testicular vessels. As the testicular vessels is going into the deep ring, that means the testis remains somewhere within the deep ring, but we can't find it into the inguinal canal on palpatory finding, and left-sided hemiscrotum is empty. But during a laparoscopic carbon dioxide insufflation, we can see the distended left-sided hemiscrotum, suggestives of patent processus vaginalis within it, that leads to left-sided congenital inguinal hernia. But testis does not encroach into the left hemiscrotum, resulting the undescended testis. The MRI finding shows the testis remains either within the deep ring or proximal to the deep ring. So we are planning for laparoscopic assisted left-sided orchidopexy, at the same time left-sided herniotomy laparoscopically. For this purpose, we have introduced the 30-degree 5 mm telescope through the umbilical port, which is 6 mm, and left and right mid clavicular port. You can see on either side, which are also 5 mm each. These are the left and the right sided working port, and you can see the distended sigmoid colon, and you can see the liver, the appendix, but there is some leakage from the port side, carbon dioxide gas. That's why the proper abdominal distension cannot be achieved here. So we have to change the port, 5 mm port. There is some problem with the 5 mm port valve, that's why gas is leaking out, and pneumoperitoneum cannot be properly achieved. Yes, now you can see the distended sigmoid, and through which just superficial to it you can see the left sided vas deferens, vas, testicular vessels, and the external iliac vessels. And we have to follow our searching for the testis, so we have to follow the testicular vessels. and inadvertently we can diagnose where the testis is. So as you can see that the left sided testicular vessels is going into the deep ring, and the patent processus vaginal is giving rise to left sided hemiscrotum swelling. So there is left sided congenital hernia, inguinal hernia. So we are going to repair it by herniotomy. And first is our step, with the help of the bowel grasper we are just searching where the testis is. You can see the psoas muscle, the iliac vessels. It is the psoas muscle, the iliac vessels. On the side of the iliac vessel you can see the ureter, the peristaltic movement. It is the deep ring, the peritoneum. We have to separate for the enlargement of the testicular vessels, so that the testis can easily be taken down. It is the psoas muscle overlying which the iliac vessels. The momentum is coming in view. Inadvertently taken within the instrument, it may stuck. Yes, you can see the vas here beautifully on the left side. And urinary bladder is to some extent distended, thus we have to positioning the patient, that is the head and down and pelvis up. It is the distended urinary bladder. You can see it. And on the right side we are going, you can see the vas medially and testicular vessels laterally. Same is on the left side, but testis is missing within the abdomen, and thus we are palpating the deep ring and it is remaining there, stuck there. So our purpose is to separate the testicular vessels along with the peritoneum, not to damage it. And don't violate this triangle, because we are dissecting in this region. It is the triangle of doom. So the iliac vessels may be injured if you not take care it properly. You can see the testicular vessels and iliac vessels which is dancing. Now we have to take the scissor, endo scissor and the Maryland forceps for proper delineations and retrieval of the testis. If you can't see any testicular vessels within it, then you will be sure that the testis is not eventually developed. On the right side you can compare it: medially vas, lateral testicular vessels, Here is also same, medially vas, laterally testicular vessels. It is on the right side, it is on the left side. Our pathological site is left side, and we are going to separate or tease this testis out from the deep ring. Otherwise we can't take it down. You can see the triangle beautifully. All the structure is properly delineated here. Psoas muscle, the testicular vessels laterally. The ureter you can see near the testicular vessels is the peritoneum. So we have to separate this lateral peritoneum along with the vessels so that the testis can easily be brought it in the abdomen along with the gubernaculum testis, and the herniotomy, that is the sac, patent process vaginalis sac, has to be cut open. The herniotomy has to be performed at the same sitting. Now we are going to see the proper area from where our dissection will start. We are just delineating the maximum traction site. So it is the maximum traction site, you can see. So we have to separate this traction site along with the testicular vessels, not to hamper the vessel. Medially you can see the vas, and we have to tease in between this two. Now with the help of this Maryland forceps, small peritoneum is teased, and with the help of the diathalamic hook we have to introduce the gas. To take the testis out from the impacted deep ring. Otherwise we can't remove or take it down. So this processus vaginalis, patent processus vaginalis, through which carbon dioxide gas entered into the left sided hemiscrotum and giving the swelling or the pseudo sac formation. So we are going to tease this area with the help of the Maryland forceps. Just hold the peritoneum, not the vessels at all. The peritoneum is lifted out with the help of the Maryland, and with the help of the diathalamic hook. We are just going to the exact area from where our dissection should start. This is the area through which we can separate the peritoneum, and we are planning to do. So we burst it. And now we have to introduce our diathalamic within this opening of the peritoneum, so that we can separate the peritoneum and retroperitoneal separation is the main thing, so that no traction should remain over the testicular vessels, and it can easily be brought it down into the hemiscrotum. With the help of the endoscissor, we are dissecting out. At the same time, blunt and sharp dissection both can be performed with this endoscissor. So we are using it. Our traction is getting changed from one to another, and you can see the testicular vessels remains medially towards the end of the endoscissor. You can see the testicular vessels can be visualized, and small cut is needed, and we have to separate this peritoneum so that the peritoneum lengthening can be done. Yes, we have to separate it with the endoscissor. Endoscissor is an excellent instrument for separations in peritoneum, both in inguinal hernial mesh repair, abdominally, laparoscopically we can do this. You can see the testicular vessels. We have to remain lateral to these vessels and stick to the peritoneum, not to damage any other structure. We are just creating blunt and sharp dissection simultaneously, so that the testicular vessels getting separated from the peritoneum and it becomes lengthened out. Now again the peritoneum has cut. It hasn't cut properly. So as much as you cut and go as you want, cut as you go as per your dictum, depending upon the length of the testicular vessel that has been achieved. Small cut is necessary always. You can see the after cutting, the testicular vessels becomes free from the retroperitoneum traction, and it can be lengthened. You can see the vast difference. So we are cutting just lateral to this vast difference, not to injure it at all, and going to this area, because this is the area through which the process of vaginalis has entered into the hemiscrotum. So we are just opening wide the deep ring to take this testis. You can see some extent bleeding is there. Yes, through the deep ring and far abdomen we can palpate it with our fingertip whether the testis remains there or not. Yes, it is in the mouth of the deep ring, so we have to take this neck area to some extent, traction and is applied, and from the abdomen, outside of the abdomen, we are pushing this testis in so that proper testicular descent can be achieved and peritoneal herniotomy can be done at the same time. So we are going to take this area the testis has to be separated. There is adhesions of the testis with the deep ring. We are trying to pull the peritoneum along with the testis because there is nothing to hold the testis, so we are in left hand we are pulling and simultaneously with the right hand pushing from the outside. We can see that the lumen vessels has been not taken into the instrument. It is only the peritoneal layer that has been traction, because after proper retrieval of the testis from the deep ring we have to grasp the gubernaculum testis. Apart from the gubernaculum, none of the area should be touched. So we are pulling and pushing at the same time and try to taking care of this testis and testicular vessels and the vas so that nothing has been damaged. Now the endo scissor has been introduced and pulling of the peritoneum. At the same time, the endo scissor we are just taking care of and take this mouth wide of the deep ring to take out the testis. The patent process vanillic sac has been grasped with the help of the, you can see the vas just medial to this tip of the Maryland, so it has to be taken care of. We are just holding the peritoneum because we have nothing to hold. At the same time, now we are again changing our traction and counter traction. We are just holding the peritoneum and the fat around it and trying to pull out the testis from the deep ring because it is clasped within the deep ring. And patent process vaginalis sac, you can see we are brought it out. You can see the testis, which is remaining here. You can see the testis in this area. With the help of the endo scissor, we are trying to separate it, and with the help of the left hand, we are pull it in. Now the superficial peritoneum has been cut, and traction and counter traction is applied. This is the testis, and we are just separating this testis and processus vaginalis sac. You can see the vas and testicular vessels on either side of this instrument. Now with the help of the bowel grasper, we are just grasping this peritoneum. And with the help of the Maryland forceps, we are trying to pull it out. We are just separating the patent process vaginalis from the testis. So traction and counter traction is the main thing for proper testis to be brought it down. You can see now the testis which is coming out. It is impacted at the deep ring and it is not moving at all, so it is very difficult to put it down into the left hemiscrotum. You can see the testis. It is the left testis that has been remaining at the deep ring and it is plastered. So we are going to take care of the testis and epididymis, but we are going to grasp the gubernaculum of the testis, which is adhered with the patent processus vaginalis. There is a tunica vaginalis which is inside the left hemiscrotum. Yes, we are just holding this gubernaculum and trying to separate it from the pseudosac. We are going to take the actual bowel gasper small for this pediatric case. The bowel gasper we are initially using is large one, so it creates difficulty during holding, so we are going to use the small bowel gasper so that we can hold the gubernaculum tightly, and at the same time we can separate it. We are trying to pull this and try to separate it from the pseudosac. We are going to change the bowel gasper into a small one so that we can hold the gubernaculum. It is the small bowel gasper. It is perfect for the age group. Now we are tease this gubernaculum of testis and the patent process vaginalis. You can see the vas, you can see, which is hanging through this. So we have to take care of this vas, not to damage it, and we have to separate this gubernaculum. You can see the patent process vaginalis sac, which is transparent and bluish. It has to be separated and cut, that is herniotomy has to be done. Now we are going to use the diathermy hook for separation. You can see the vast difference in position, testicular vessels in position, cutting this only gubernaculum from the patent process vaginalis sac. That is the pseudosac, which is nothing but the invaginating layer of the transversalis fascia. We are just separating it, and this separation creates extra length to achieve for the testis. You can see the length that has been achieved. You can see now the testis has been veiled with gubernaculum only, and lateral peritoneum has been released. The lateral peritoneum has been released properly. The vast difference in position. The gubernaculum of testis is held with the Maryland forceps. Again, some peritoneal release is achieved. You can see the separations, and we have to check whether adequate release is achieved or not. The testicular vascularity is well maintained, no issues, and that can be checked with the holding of this gubernaculum testis to the opposite deep ring. We are just trying to hold it with the bar grasper and pull it towards the opposite ring, deep ring. If it is easily achieved, the distance can be easily achieved. Yes, then no traction. Some kind of traction is there, so we are trying to release slightly the lateral peritoneum. We can see up to which extent release is needed. So with the help of the endo scissor, we don't prefer to use right now the diathermy, because we are doing job near the vessels, testicular vessels. So there may be lateral thermal damage may happen. So we are just releasing this bit of peritoneum, and you can see the testicular vessels has been exposed. Now the full length has been achieved. Now it can be easily going towards the deep ring. You can see the triangle of doom and the location of deep ring. So more than enough release of the peritoneum is done. Now it's our job to grasp this gubernaculum through the left-sided hemiscrotal skin incision. So we are now going to create the left-sided hemiscrotal incision at the bottom with the number 11 blade, making the subdartos pouch with the artery forceps, and now a small curved hemostatic forceps has been introduced through the superficial ring and going towards the deep ring. You may take it directly medial to this epigastric vessels, but there will be chances of direct hernia in lateral life may happen. So we always prefer to do the natural path, though this natural path through deep ring to the inguinal canal, then through the superficial ring, needs some extra length to achieve. So when our length achievement is adequate, then after confirming it, we are just introducing the hemostatic forceps, curved hemostatic forceps through this left-sided hemiscrotal incision. After making the subdartos pouch for testis to remain within there, we are introducing the curved hemostatic forceps just through the superficial inguinal ring, then through the inguinal canal, then through the deep inguinal ring, remaining lateral to the epigastric vessels, inferior epigastric vessels, so that the flap valve mechanism will act as before, not to jeopardize this flap valve mechanism. And you can see the distended urinary bladder. After operations, we are providing the catheterization of this patient. You can see my tip of the hemostatic forceps, which is going medial to this, so I am always trying to puncture the lateral one. Yes, through the lateral one you can see it is coming out. Now we are going to grasp the gubernaculum testis tightly. We we are tightly take it, and after proper grasping, now it has been grasped, it is released, and it is pulling out, it is pulled out, making and taking care not to rotate this testicular vessels or epididymis, maintaining their triangle, which is remain medial to medial and which is lateral to lateral, not to rotate it. And we are now going to suck this blood, and we have to see whether our bleeding spot is there, so we have to secure it first. So after thorough peritoneal wash, we will see from where the bleeding is coming or not, and after doing this, we will decrease the abdominal pressure and release it, and we will fix it outside with the subdarter space. In the subdarter space, either with the PDS or with the Vicryl suture, we have to wash it thoroughly, warm saline. So here we have performed the herniotomy as well as the testicular descent orchidopexy surgery. You can see no vital structure has been touched. Vast difference you can see, testicular vessels you can see, and now our job is to flush and taking out this blood clots or bloods. Hemostasis is needed and achieved properly. You can see that I am seeing external iliac vessels. Now thorough peritoneal toileting and wash is going on. So warm saline toileting is going on, and we have to see whether any bleeding coming out or not, proper hemostasis has been achieved or not. After being confirmed regarding the hemostasis, we have to move on to the extra-abdominal testicular fixation with subdarter space. So warm saline toileting is needed. It is very important step. And no drain is needed at all. And before removal of the patient from the operative table, we have to make sure that the bladder should remain empty with the catheterization. And entire surgery is performed under GA anesthesia with endotracheal intubation, as the patient is a small little one, a little boy with some history of panic attacks. So we don't put any spinal anesthesia here. We are doing only under general anesthesia. And the weight of the baby is around 20 kg. So we have to be more cautious because the abdomen should remain dry, otherwise this abdominal fluid may be absorbed and create some fluid overload for this baby. So always try to take this fluid out and make it dry, the abdomen, and after that you can move on to the outside of the abdomen, further procedure. So again we have to suck the whole area, and now as because of the area has been, now you can see is going to be dry properly. Again some fluid is there, so we have to suck it. After proper positioning of the patient, initially the head end remains down, so we now make the patient supine, and the fluids that is going in towards the thorax is coming out and collected within the abdomen. Now it has been collected into the pelvis, thus we have to suck it out, and all the fluid that has to be taken care of has to be removed, otherwise some interabdominal abscess may formation. This fluid sometimes creates some problem later on, so we have to thoroughly make it dry after sucking it. So we have sucked out this fluid, no active bleeding is there, the color is also good. Now we are just separating it, and momentum is sometimes here plugged in to the sucker machine, sucker tip, cannula, creating problem. Small area that has been making dried. Now we are just moving out from the abdomen, and now we are concentrating over the subdartos fixation. You can see the subdartos fixation here, you can see the testis, and operation done.